consultant at Moorfields. I have no financial disclosure. So convergence excess esotropia is an esotropia with a binocular single vision at distant fixation. However, the esotropia is on accommodation at near fixation with a near distance disparity of more than 8 prism diopters. Much of the controversy that has arisen in the management results from the differentiation in the definition. Another acceptable definition of the convergence excess would be a convergence squared of more than 8 prism diopters in near more than distance after full hypermetropic correction. Apparently, we are not dealing with a homogeneous group of patients. So the primary aim of this work, this was a retrospective review from the electronic database. It's not the paperwork. So some of the details might have been deficient. Initial treatment modality was successful or not, whatever it be. And the definition of success is an esotropia of less than 10 prism diopters at near or distance, with or without the glasses, in the presence of binocularity. We did also look at the endpoints, presence or absence of esotropia, binocularity, and whether these patients were able to eliminate bifocals or not. So this was a retrospective review of all patients managed with convergence excess esotropia in their diagnosis of Moorfields in the electronic database from 2003 until 2022. We have included patients with a diagnosis of convergence excess with a binocular single vision at distance, but esotropia on accommodation for near, with a near distance disparity more than 10 prism diopters, with the eye having full cycloplegic refraction. We have also included all age groups. We did not exclude very young age or very old age. We have excluded patients with amblyopia or any ET at distance despite the full hypermetropic correction. We have identified 668 patients, 60 of them were excluded and left with 608 patients. The mean age was about 8.3 years, ranging from 2 years old to 60 years old. Obviously, very few patients with these extremes, and the main referring symptom was a deviation in the primary position, basically esotropia, in 42% of cases. 16 patients were having diplopia as a primary referring symptom, and the rest were unspecified. Even though the ACA ratio was measured in most of the patients, but it was not documented in the notes, only documented in 50% of the patients, and they were mainly either normal or high ACA ratio. Only 2 patients were having interestingly low ACA ratio. We did also look into the systemic associations, and even though deemed non-significant, there was an increased trend toward the ADHD, autism, and the anxiety disorders. And these were particularly in the older age group with the low ACA ratio. Bifocals were offered in the majority of cases in 62%, with an 80% success rate. Surgery was offered in only 9% of cases, and I have a disclosure here. The surgery is no longer offered as a primary or initial treatment outcome in Moorfields, and this was back in the day, I think until 2005. Magnetophone and pilocarpine as well were also offered for the patients with diplopia. And the surgery was mainly bimeter recession of up to 5 millimeter. Recess resect, fadden suture, and Scott procedure were also offered, but none of the patients who had recess resect or the fadden did manage to have a successful outcome as an initial treatment. So the second treatment option depended on whether the first treatment option was the surgery or the bifocals, and the second treatment was the other way around. And we did find that 90% of the patients who were initially offered bifocal and then offered bimeter recession were successfully controlled after the surgery, suggesting that surgery offers a higher success rate when it comes as a second line of treatment after a period of optical correction in cases of high ACA ratio. On the other hand, only 70% of patients who were initially offered surgery, and the surgery was only offered in 9%, were controlled with a period of optical correction with bifocals. We have patients who had undergone fadden suture as an initial procedure or a second procedure after BMR, and it seems to have a low success rate in this cohort. The endpoint results: 60% of the patients were discharged with a well-controlled folia, 3% were discharged with a microtropia, and consecutive exotropia or residual esotropia were found in 34% of the cases. And interestingly, the elimination of bifocals were about 40% of patients, which is something interesting. Many of the patients were asked for an exact figure or exact percentage, what's the chance of my kid getting rid of the bifocals and at what age? And 25% were discharged from the hospital with the bifocals. No availability of data was found in 34% of cases. And the average number of visits was about 6 visits, ranging from 1 to 25 visits, and obviously those with more than 10 visits were the ones having the surgery. The binocularity was achieved in about 50% of the cases, and even though this is a high percentage in itself, but this number is thought to be higher because we looked only at the documented binocularity. So there might be cases with binocularity, but it was not documented on the notes at the time of the discharge. And the average of 2.6 years of visit, which is again interesting number, how long will my child be followed up until discharge? And even though hypermetropia was the most common refractive error, 2% of the cases were found to be myopic. In summary, the average age of presentation was about 8 years. Although the high ACE ratio is common, in older age group, look for drugs causing hypoaccommodation in cases of low ACE ratio. And evidence of higher success rate with bifocals as an initial treatment, then followed by the surgery, and a biomedial recession. The standard practice in more fields is a recess resecting in every single patient. Apart from the convergence excess esotropia, the biomedial recession was deemed superior. 40% of the patients of this cohort could eliminate the bifocals, and about 50% did achieve documented binocularity at the discharge time. And the average hospital visit 6, with an average years of 2.5 years of follow-up. Although this is considered one of the biggest case series, 600 plus patients, we need more data and subgroup analysis because we did not differentiate different types in different groups. We don't have long-term outcome after the patient were discharged, even though we do have some patients who have been there for 10 years, and ACE ratio was not documented in all cases. These are my references. Thank you.